This conference will now be recorded.
All right, so we'll go for about an hour or so, and then we'll take a break and try to finish up. So we're only doing this one lecture tonight, just on airway management. Keep in mind that airway management takes a big part of what we do in the field. Airway is part of our ABCs, right? So it's what we're looking at, what we're doing, always monitoring and maintaining that airway as well. A lot of different procedures, maneuvers, things that we can utilize to help maintain and keep a patent airway as we look through it all. So let's do some review. Let's get some of this stuff out of the way so you can see my screen here. All right, so we're going to meet all the different standard competencies, EMS education standard competencies on airway management, respiration, and artificial ventilation. So some stuff will be review, some stuff will be new for you guys. We're going to do a review of airway anatomy, then we'll look at airway assessment, and then different techniques of assuring that airway is patent. Excuse me. Also looking at anatomy and respiratory system, looking at the physiology and pathophysiology of respiration, looking at pulmonary ventilation and oxygenation, as they are two different things. We're going to look at respiration for internal and external and cellular respiration, and why we do things that we actually do in the field to treat these patients, whether we utilize CPAP, non-rebreather, nasal cannula, simple mask, or even a little bit we'll discuss on the high flow nasal cannula now. We're starting to see a lot more of that as well, which is something that's new for us, at least in pre-hospital medicine. And also supplemental oxygen therapy. We're also going to look at assessment and management of the adequate and inadequate ventilation, making sure we're getting good minute volume, alveolar ventilation, and the effects of artificial ventilation on cardiac output, and also looking at artificial ventilation as a whole. And then obviously the wonderful pathophysiology behind it. So this will apply a comprehensive knowledge of the pathophysiology of respiration and perfusion to a patient assessment and management, and why it's so important to make sure that we're ventilating appropriately. We'll look at different scenarios. I'll throw some other real life scenarios at you as well during this in regards to the ventilation, but also taking airway management and incorporating that with waveform capnography to make sure they're actually off-gassing and ventilating appropriately. So the most important steps in caring for any patient are obtaining and maintaining a patent airway and assuring that the patient is breathing adequately. Right? Kind of a no-brainer. We got to make sure that they are breathing adequately. If they're not, then oxygen will not be able to reach the body's tissues and cells, therefore will not allow for good circulation, right? So we need to make sure that the oxygen is reaching those body tissues and cells through breathing and circulation. But sometimes they're kind of, sometimes we come into contact with patients like COPDers or pneumonia or septic patients, things like that we really can't get that oxygen to the cell. And sometimes they need a little bit more of a push to assist with that. So the respiratory system consists of all the structures in the body that make up the airway and help us breathe or ventilate. So the airway is divided into the upper and lower airways, right? Upper and lower. We're going to cover that in the next slide in the review. So the structures facilitating oxygenation and ventilation include the diaphragm, the muscles of the chest wall, accessory muscles of breathing, and then the nerves from the brain and spinal cord to those muscles. Then we have ventilation, which is the exchange of air between the lungs and the environment itself. That's our ventilation. So kind of looking at this figure here, it kind of shows the structures of the upper and lower airway. Understand where the difference is as far as where the breaking point would be. So we have the upper airway, which is the nasopharynx, the nasal air passage, obviously the pharynx, you can just follow the arrows over, the oropharynx, and mouth epiglottis and larynx. Once we pass the larynx, getting into the trachea itself, that's where the lower airway actually starts. So our asthmatics, our COPDers, things like that, our CHFers, that's going to all be lower airway issue. Our anaphylaxis, our croup, things like that, epiglottitis, things we're going to run into for pediatrics. That's all going to be upper airway, right? So we got to be able to differentiate the difference of where this problem actually is occurring. So in the lower airway, we have the trachea, and it goes right down through the trachea to the carina, which is the split off here, right? That breaks into the bronchioles as it branches off. The right main bronchus, into the bronchioles, and then the bronchioles then lead into the alveoli, right? The alveoli are where the pulmonary capillaries are located, and this is where that gas exchange is happening. So air comes in, right? Oxygen, 21%, attaches to the red blood cells, hemoglobin. Then also off gases, carbon dioxide as you exhale, and the process goes round and round, right? This is a normal, good working airway, right? The problem is when we start throwing different wrenches into it, like a patient that has COPD, emphysema, bronchitis, asthma, or all three, pneumonia, all things that could cause or inhibit the alveolar function. So the pulmonary capillaries can no longer provide decent gas exchange, causing a patient to become hypoxic. So the major functions of the upper airway are to warm, filter, and humidify air brought into the body. The pharynx is composed of the nasopharynx, oropharynx, and laryngopharynx. So the larynx is considered the divided line between the upper and lower airways. So the major function of the upper airway, we talked about, remember again, is warm, filter, and humidify. You're going to see that on an exam again. I guarantee you'll see that. All right. The upper airway is to warm, filter, and humidify air brought into the body. No worries, Jen. All right, so as you can see, the upper airway kind of consists a little more in depth. Now, this is where we start going into the ALS stuff, right? So as we're looking into the airway, this is what we're going to see. Obviously, the upper lip, the palatine tonsils, looking down through the uvula, tongue, lingual, vestibule, and then gingiva, as you can see down here. All right, stand by 1 second. Someone's having a hard time with the go-to meeting. We'll be right back. Someone's trying to log in. Hey, sorry, back. One of our students is having a hard time logging in. Should be coming in here any second now. I just resent him the link. And there he is. Hey, Justin.
How's it going?
Perfect. Perfect, perfect. All right, so we're doing airway management tonight, chapter 11. All right, so again, just so you know, Justin, this is being recorded. we put up on the website within 48 hours. You can rewatch this. And all the other lectures we've done since the first class are all there as well.
Okay, I watched the first one today.
Perfect. I apologize for how boring the first couple chapters will be.
Yeah, it's okay.
All right. So let's get started up here again. All right, can everybody see the screen okay? I moved a couple things around. Yes, perfect. Also, Justin, there is a chat box you can utilize that I do monitor as well. So if you can't reply back through verbal, you can always reply in the chat box as well.
All right, sounds good.
Sweet. All right, moving forward. So we have obviously with the upper airway, right? So nasopharynx, oropharynx, and laryngopharynx, as you can see in the picture on the right-hand side as well. With this, so it's more the upper airway anatomy. This will show more of the oral cavity and the pharynx. Let's go. Oh, there we go. So let's go a little more in depth in the nasopharynx. These are formed by a union of facial bones. There's quite a few facial bones under there, right? So in union, it forms the nasopharynx, which is divided by the septum and lined with ciliated mucosal membrane. So cilia helps move contaminants out of the body, right? We have to have the cilia, that hair-like type, that helps protect and move things around. We have turbinates that are more built into the nasal mucosa. So these are increased surface area of the nasal mucosa are called turbinates that help filter and move that air. Then we have sinuses that are cavities formed by the cranial bones. Fractures of certain sinus bones also may cause a leakage of CSF into the nasal passageway and auditory canal. We'll talk about that in a second. And then the tissues of the nasopharynx are extremely delicate and also very highly vascular, right? So again, extremely delicate, highly vascular, anything in the nasopharynx, which is why we have a lot of things like nosebleeds and things like that that can be detrimental if not controlled. Now, I know we get called, oh my God, we're going for a nosebleed. Why are we going to this call, right? You get there and it looks like a bloodbath inside the house, right? That amount of blood loss can actually cause a patient to go into shock. Well, let's talk about fractures, right? So how can we test? What is that test called to be able to check and see if someone has cerebrospinal fluid coming out? What is that called? Yeah, the halo
test.
Yeah, exactly, halo test. I see Justin and Matt putting halo. I think that was you, George, that said that as well. So awesome, good call. So how do we check it?
Dip a folded 2x2, 4x4 in the fluid.
So kind of like Justin's saying, like George, like you were saying, like the gauze touch. So really what you're looking for is the fluid, the blood coming out of the ear or nose. You kind of catch it in a 2x2. As it connects, you'll start seeing that golden halo around the blood. It'll kind of separate, and that'll be your halo check that you guys are talking about. And that's a significant injury when we have this kind of stuff. We have cerebrospinal fluid coming out. As you can see, the sinus bones may cause that type of leakage into the nasal pathways and the pathways. I can't speak today. In the auditory canal. So, is this something that I expect you to do in the back of the ambulance? I guess that's a question to ask everybody. Do you check for this? Is it top priority? What do you think?
Not really.
Okay, at first, we got to manage airway, right? ABCs. Control any major bleeding, right? So I would not put this on the top of the list to check, but if you have time to collect it and look for it, absolutely. But I would put that more towards the bottom of the list. A head injury is a head injury. Nothing is going to change that, right? You're still going to treat the head injury, maintain airway management, and ALS calling for paramedics if you have if you need to have the patient intubated or if they need to be RSI'd. So there's different potentials with this, right? So we look at it. It's good to know, but remember, cerebrospinal fluid is coming out for a reason sometimes too, right? So look at all that together as a whole. Again, not something I would check right up front, but if I've done all my splinting, I've done everything else I need to do, IVs in place, cardiac monitor, fluids, pain management, things like that, I'll circle back and try to collect it and see if there's CSF so I can pass it along to the physician. You got a 3-minute transport, you're not going to hit it. You got a half an hour transport, you should have a chance to get that done. So the oropharynx, which is part of the throat found in the posterior of the oral cavity. The epiglottis is a leaf-shaped cartilaginous flap located at the base of the tongue and above the larynx. Let's go into here. So the larynx, which is formed by many independent cartilaginous structures, the main laryngeal structure is the thyroid cartilage, and the glottic opening is the narrowest portion of the adult trachea, right? So why is this important? To know. What are your thoughts? Why is it important to understand how the larynx is formed? Well, one for more of an ALS level, it's very important because that cricothyroid membrane, that's where crics are done. If anybody's doing a surgical or needle or quick trach for paramedics. What about the hyoid bone? What does that support? Anybody?
That the jaw area?
So this would actually support the tongue. Okay, it's located down low. Is that bone connected to another bone? No, it's not. So that's the only bone in the body that's not connected to another bone. It's called the hyoid bone, which is located under the tongue, kind of protects that support, and also connected through a thyroid ligament going into the thyroid cartilage, which you can see the ligaments down through here in the picture, right? So as we're palpating somebody's neck in an ALS assessment, we want to start at the top of the neck, work our way down to make sure all of this is in line, right? If we have any deviation, okay, could we have a laryngeal fracture? Could we have a tracheal fracture? Or I should say, yeah, possibility. There's a possibility it could be there. What's another sign of tracheal deviation? What does that usually indicate? What would tracheal deviation indicate? The late sign. What do you guys have? Yep, pneumo. So pneumothorax. So would the trachea deviate towards the good lung or the bad lung? Yep, the good lung. It always pulls towards the good side. Okay. But if you have tracheal deviation in a patient with a pneumothorax, they've had a pneumo for a while. I'm not saying days, but it's been some time. Because tracheal deviation is a late sign of a tension pneumothorax or pneumothorax. So the lower airway is the function of the lower airway is to exchange oxygen and carbon dioxide. The external boundaries are the fourth cervical vertebra and the xiphoid process. I'll show you guys in the next slide here in a second. And the trachea, the windpipe, is the conduit for air entry into the lungs, right? Which divides the level of the carina. So when the trachea reaches the thoracic cavity, it divides at that point, right? So how can we? It says the function of the lower airway is to exchange oxygen and carbon dioxide. Where is that exchanging again? Where does that exchange?
The bronchioles?
Keep going lower, George. Where does carbon dioxide?
Alveoli?
Yeah, exactly. Perfect. Yeah. So how can we measure oxygenation and carbon dioxide?
End tidal?
End tidal for carbon dioxide and SpO2. Right, exactly. There are two different things. Pulse oximetry and capnography, remember, are two different things. hand in hand, we can tell if a patient's oxygenating and ventilating and how they are doing it and how well they are doing it, just by looking at numbers in waveform, right? Because you may have inaccurate numbers on a pulse oximetry, especially if the patient's hands are cold, okay? So know your cardiac monitors. Cold hands do not give you accurate readings, correct? Yes, okay. So who uses, out of the services you guys work for, who uses the Zoll X series monitor?
I know we do.
Okay. Yes, yes. I see a lot of yeses, right? Do you guys know how to select different features on the Zoll X series? You push up and down arrow and it highlights blue and it goes around the monitor and you can select stuff. You've seen that before?
Yes.
Yeah. Go to pulse oximetry, okay, where you see the 98, 99%, and click on that button on the Zoll X series monitor and scroll down to where it says sensitivity and change that to maximum on an X series monitor, put it on maximum and then save it. That'll give you a more accurate reading on a cold hand because it puts it at maximum reading level of the red light inside that reads it. It'll give you a more accurate reading of patients that are cold. The only thing is, though, is light also interferes with it, so you got to put their hand underneath the blanket where it's dark. Anybody ever seen that trick before? Yeah. Change the
Not me.
sensitivity. All right, that will help you tremendously at getting more accurate readings. But on top of that, we look for two things on those, okay? On pulse oximetry, we look for something called pleth, all right? And that's when you start seeing that rounded wave. That's our pleth. For end tidal, we look for waveform capnography for the exhalation. And we'll cover that later on in another chapter. But again, we can monitor this stuff real time in the field. We just have to utilize the tools that are there for us to use them. All right. So lungs include a smaller bronchi, bronchioles, and the alveoli. So as it branches down, right? So we have the trachea coming down, right? Going into the trachea. At the carina, we have the bronchi, main stem, right and left main stem. That branches off into the bronchioles, as you can see all the other tree-like features in here, which then go into little alveolar sacs throughout the entire lung capacity, okay? And that is where our gas exchange is actually happening. Remember, each bronchi divides into smaller bronchi than the bronchioles. The bronchioles then branch into alveolar ducts. Remember that the bronchioles are thin, hollow tubes made of smooth muscle, okay? And smaller bronchioles branch in the alveolar ducts that end at alveolar sacs. The alveoli are the functional site of the exchange of oxygen and carbon dioxide. All right. So with that being said, what I'm going to use the word chemical. What part of the I think a good word to use. What chemical? I'm going to use chemical within the body lines the alveoli. It's something that is used to decrease surface tension.
Surfactant.
Exactly, surfactant, right? Yeah, that's it. So if we have a decrease in surfactant, our surface tension will become greater, causing potential for what to happen. What would happen if the surface tension became greater, causing stuff to do what? It would cause the alveoli to do what?
Would it not be able to expand as much?
Right. Then if it can't expand, what is it doing?
It's not not allowing cellular distribution.
Okay. Which therefore
Trying to think of the
I know.
Trying to think of the word.
Oh, I just brought it up for you. Collapse of the alveoli. So oxygen diffused through the lining of the alveoli into the pulmonary capillaries. And surfactant lines those alveoli to decrease surface tension to prevent atelectasis, which is the collapse of the alveoli, right? So what we don't want to happen is atelectasis. If atelectasis happens, then we can't oxygenate appropriately. Right? It doesn't allow that alveoli to, so the amount of surfactant is inadequate, or the alveoli is not inflated, and the alveoli will collapse, resulting in that atelectasis I was telling you about. Right? That's why surfactant is so important, and also making sure that we're ventilating appropriately. So we have to make sure we're providing that oxygen so it diffuses through the lining of the alveoli into the pulmonary capillaries to allow for that oxygen exchange to hit the pulmonary capillaries to pick up on the red blood cells and then start transporting it through the body on the hemoglobin and moving around and around, providing tissue perfusion, right? So if we don't have that tissue perfusion, we have an inadequate state of it. Why is that happening? Is there hypovolemia? Is it hypoxia? What is causing that to happen, and can we fix it? Right? So break things down, look at the pathophysiology behind everything, what we're doing. So we talked about in the last slide, go back one for a second here. That's not back. Right? We talked about the bronchioles, okay? So bronchioles are thin, hollow tubes made of smooth muscle, okay? If we have constriction, what do we do to help them with that?
Duoneb?
Yeah, well, albuterol. The ipratropium bromide is more of the steroid behind it, but you're right, duonems definitely work. But that albuterol, being that bronchodilator sympathomimetic medication, right, that has beta-2 and selective beta-1 effects. Okay, so we have the beta-1 effects, so we're seeing the increase in heart rate, and we're having the beta-2 effects as we're seeing bronchodilation. Right? We're seeing this stuff real time in the field. We're listening to lung sounds, hearing that wheezing. That would mean that the hollow tubes of smooth muscle are starting to constrict. We give something that can help open those back up again, and that's albuterol. It all works in one big process. With everything that we do with a cause, there's an effect to it. So unfortunately, the effect behind bronchodilation is going to be tachycardia as one of the side effects to the medication. All right. So between the lung space is called the mediastinum, which is surrounded by a tough connective tissue. This contains the heart, the great vessels, the esophagus, and the trachea, along with the major bronchi and many other nerves. The phrenic nerve innervates the diaphragmatic muscle, allowing it to contract. All right. The respiratory and cardiovascular system, they work together. They ensure the constant supply of oxygen and nutrients to every cell within the body. And they ensure that the carbon dioxide and waste products are removed from every cell in the body, right? So we have air coming in, the heart has to pump in order to move the red blood cells around, provide that oxygen and gas exchange, right? So if our heart's not pumping effectively, can we go into shock?
Yes.
Yeah, yep, exactly, right? So now we got to figure out, why is the heart not pumping effectively? Are they in cardiogenic shock? Are they in hypovolemic shock? Are they in distributive type shock, obstructive type shock? What kind of shock are they in? And we can tell a lot of this just by listening and taking vital signs, right? There's a lot of things that we can do to find out what's wrong with our patients. Look at everything that we do. If a patient has COPD exacerbation, are we oxygenating appropriately? Who can run me through that? A patient that has a hard time breathing, let's say they have COPD, emphysema, okay? You get to the scene and your patient has a pulse oximetry reading of 60%. What would you expect, and then with good pleth, so you know it's accurate, what would you expect to see on your patient presentation? What would you see in this?
Cyanosis.
What was that?
I would see cyanosis,
Okay.
retracting, difficulty breathing, maybe posturing, like tripoding.
Okay. So you threw a bunch of those things out. I got Justin saying cyanosis. Exactly. We would see that as well. Probably pale skin, right? So break that down even more. Let's go more in depth. What else is going on when the patient has all this? Would you expect to see what else would you see for the heart? Would it be
Tachycardic?
Yeah.
Could be tacky.
All right. So London just posted rapid heart rate. If you're able to talk, London, why would you see a rapid heart rate?
The heart's working harder to oxygenate the body.
Okay, no, Mike, got it. So your heart's working harder because it's going into potential.
Cardiogenic shock?
How about compensated shock? We're seeing if your body is if your respiratory, rephrase that. If you have a COPD exacerbation, we're going to see. That's fine. Sorry, no worries, London. Right, we're going to see the patient become tachypnic. Right, what is tachypnea? Elevated respiratory rate. Perfect, right? So we see a faster respiratory rate. We're seeing a faster heart rate. So now your body is trying to compensate for the fact that they're having a ton of bronchoconstriction based on that emphysema, right? So we have decreased oxygen levels. So our body's going to say, we need to replenish this. Let's bring the respiratory rate higher. Let's bring the heart rate higher. So that way there we're breathing faster, tachycardic, more oxygen trying to come in and trying to pass through the body systems faster, right? Unfortunately, that doesn't always work. So we have to fix that problem in the field. We have to fix that quickly because a patient that sits at an oxygen saturation of 60%, okay, they're tachypnic. So what would the end tidal be? High or low?
High?
Go the other direction. Let's go low, okay? So we're going to see a low end tidal because now our patient's not off-gassing appropriately, right? So if we had a patient breathing like 8 times a minute, okay, we would see high end tidal. A patient that has tachypnea, we're going to see a low end tidal. So now the patient's not off-gassing appropriately. We're not getting that good carbon dioxide exchange. What can we do to fix that problem? This patient cannot breathe. This patient's going to go, so with hyperventilation, London, you would see a low carbon dioxide level. So you would see like 18, 20, any kind of tachycardic, any kind of tachypnic rhythm that you would see in a end tidal would be a low end tidal.
Would we use CPAP?
Yes, exactly. So we're going to apply CPAP to the patient, providing PEEP, positive and expiratory pressure, to help open up those lungs. And in the process of doing so, we can give a nebulizer inline so we can push that medication down farther into the lungs, allowing for a better oxygenation, right? It's amazing. Understanding the pathophysiology behind what you do and what you're doing for the body, you'll see changes. Control their breathing, get their rates down below 40, right? Let's get it down to the mid 20s. You get that down to the mid 20s, you're going to see that the oxygen levels will start coming up, the heart rate's going to start coming down, and your end tidal is going to try becoming more normal, right? All that because you applied CPAP to a patient with 100% oxygen, okay, and giving them an inline neb. Just those two things alone can truly save someone's life and prevent them from being intubated. That's your pathophysiology behind breathing, put into real terms, right? Time is critical. Sufficient external ventilation and perfusion are required to deliver adequate oxygen, right? So 0 to 1 minutes, cardiac irritability. 0 to 4 minutes of no oxygen, brain damage not likely. 4 to 6 minutes, brain damage is possible. 6 to 10 minutes, brain damage is very likely to happen. More than 10 minutes, irreversible brain damage, right? Do we want these patients to be unoxygenated? Absolutely not. You got to make sure things are sufficient. Now, I'm surprised no one's asked me yet, and then most of you guys probably already know the answer to it. Oh, well, they're COPDers. They live in the upper 80s anyways, right? It doesn't matter. Truthfully, it does not matter where they sit on a normal basis. If they are struggling to breathe and it's outside of their norm, we have to oxygenate. If you take a COPD patient that's a CO2 retainer, okay, carbon dioxide retainer, and you give them 100% oxygen to bring their oxygen levels to 98, 99%, it is not going to hurt them short term. Now, if you built them on BiPAP or CPAP for days on end, absolutely it can do more damage. But for short term, they need that oxygen boost to get them out of that exacerbation phase, along with bronchodilators and smooth muscle relaxers, right? And one of those smooth muscle relaxation is not something that an AEMT can give. Paramedics have it. It's called mag sulfate, right? But you do have, and then they also have the steroids. Medics have dexamethasone or solumedrol as well. But just at the advanced EMT level with CPAP and having the ability to get inline nebs, phenomenal. And patients are not being intubated as much. I didn't want to go too much in depth on this, and we're going to talk respiratory later. But having the understanding with a scenario base on top of that, what we're doing in the field now, because of the evidence-based medicine, we're fixing patients quickly with rapid intervention of CPAP. Any questions on that at all?
Yeah, I just was wondering, isn't there a condition that it's bad to give CPAP for? Is it CHF that can exacerbate an underlying condition?
Not CPAP. Albuterol, yes. So patients that have a lot of pulmonary edema, even if you hear a little bit of wheezing, that can cause a patient to flash internally. But CPAP is actually indicated for acute pulmonary edema from CHF. So
Okay.
I think that's what you were thinking, George, was the albuterol, not the CPAP for the med.
Yeah, I'm sure it was. I just remember hearing it was something that could
Yep.
exacerbate.
So that's why the big old discussion it's always been COPD versus CHF. Now, Matt made a good point on CPAP. You know, we're not discussing CPAP too much, but a pneumothorax it's contraindicated. So you have to have air movement in both lungs in order to utilize CPAP. And on top of that, the patient also has to be able to maintain their own airway. So if they're in and out of consciousness, you're going to BVM. Do not use CPAP on altered patients. Because if they can't maintain their own airway and they vomit into that mask and it forces it into their lungs, we got a bigger problem at hand. So ventilation is the process of moving air into and out of the lungs. Inhalation is an active muscular part of breathing, where air enters the body, through the mouth and nose and moves into the trachea. The diaphragm and the intercostal muscles then contract and the lungs fill with air. At this time, the ability of the lungs to function properly is dependent on the movement of the chest and the surrounding structures. The thorax, thoracic cage, diaphragm, and accessory muscles. The diaphragm is a specialized skeletal muscle which functions as both a voluntary and involuntary muscle, right? The ability to function properly. So things can change. Trauma, positions of the patient. A patient that weighs 400 pounds lying on their back, they may have a harder time to breathe. Lying on their chest, harder time to breathe because they're so heavy that they have what they call positional asphyxia. Okay, so you got a bigger person on the stretcher and they're lying down flat, and you're like, why aren't the oxygen levels coming up? Why can't they breathe well? Sit them up, get them up where they belong. Unless we have a suspected spinal, if it's truly a medical only, then sit them up and give them some oxygen. You'll be amazed at just how much that will change someone's breathing pattern. All right, so partial pressure is the amount of gas in air or dissolved in fluid, such as blood. Okay, this is measured in millimeters of mercury. The body attempts to equalize partial pressure, which results in oxygen diffusion across the membrane into the blood. Atmospheric pressure is normally higher than air pressure within the thorax, so during inhalation, a slight vacuum is then created. Gases such as oxygen will also then at the point move from an area of higher pressure to an area of lower pressure until pressures become equal. The entire process of inspiration is focused on delivering oxygen to the alveoli, so breath in. Variations in tidal volume, respiratory rate will both affect the minute volume, right? So if a patient doesn't have good tidal volume, one of them being rib fractures, or COPD, or emphysema, asthma, bronchitis, right? All those things there. Trauma to the chest, pleural effusions, hematomas, things like that that can cause any kind of or inhibit that process from happening, right? Can decrease tidal volume. Patients that have faster respiratory rates will change minute volume, right? We have to be able to fix all this stuff, and then we can fix it by utilizing CPAP. We can fix it by utilizing nebulizers. We can fix it by utilizing BVM. We need to figure out how do we fix that ventilation process at that point. Exhalation is a passive process, which does not require any muscular effort. All right? The Herring-Breyer reflex is a feedback loop that prevents overexpansion of the lungs by terminating inspiration. Relaxation of the diaphragm and intercostal muscles then increase intrapulmonary pressure. So when the size of the thoracic cage decreases, air in the lungs is then compressed into a smaller space, increasing air pressure. So the maximum expiration occurs when the diaphragm and the intercostal muscles relax and the air is exhaled forcefully as opposed to the normal passive process. So inhalation, air in, exhalation, air out. The regulation of ventilation involves a complex series of receptors and feedback loops, in which the drive to breathe is based on pH changes in the blood and the CSF, cerebrospinal fluid. So in healthy people, when oxygen levels rise, the respiratory center then suspends respiration until the rising carbon dioxide level stimulates the respiratory center to breathe. So inhalation, exhalation, and it's all done based on pH. So our body can actually read that. Okay, we cannot technically check pH in the field, but what can we utilize to help make sure that patients are ventilating appropriately? It's the same thing we always talk about.
SpO2?
Well, that's oxygenation. Let's talk about ventilation, all right? So SpO2 is oxygenation, right? So George, what would the other one be?
Exhalation, and it would be capnography.
Capnography, perfect, good job. End tidal CO2. Oxygenation, pulse oximetry, ventilation, end tidal. Together, we can treat patients. Awesome, good job. So oxygenation is the process of loading oxygen molecules onto the hemoglobin, red blood cells, molecules in the bloodstream. Adequate oxygenation is required for internal respiration to take place. Our body has to start doing this to metabolize. Respiration is the metabolism where the cellular respiration cells take energy from nutrients through a series of chemical processes. We'll get to that in a moment. Each cell combines nutrients and oxygen and produces energy and waste products, right? The process of exchanging oxygen and carbon dioxide occurs by diffusion. Why is it diffusion? Because it's a gas, right? Osmosis is a liquid, diffusion is a gas. External respiration which is the process of breathing fresh air into the respiratory system, then exchanging oxygen and carbon dioxide between the alveoli and the blood at the pulmonary capillaries, right? So good stuff out, in, bad stuff out. Adequate ventilation does not guarantee external respiration, though, okay? The hemoglobin molecules pick up fresh oxygen as it crosses the alveolar membrane, right? Just because you're breathing does not mean that we're oxygenating. So we have to take a look at that, right? We have to look at the pulse oximetry. We have to look at the end-tidal CO2. We have to look at the patient presentation, skin, color, temperature, condition, respiratory rate. Is it fast, slow, shallow, rapid, right? What is it doing? Is it irregular? Could it be a patient in diabetic ketoacidosis and they're breathing with Kussmaul respirations to help change that gas process in the system, right? So over there, we have the excessive release of ketones. We'll get to that in endocrine, but we got to look at that rest, the inhalation, exhalation, and ventilation as well. So internal respiration is the exchange of oxygen and carbon dioxide between a systemic circulatory system and the cells of the body. As you can see, blood cells coming in carrying the good stuff. It goes in to the tissue cells, oxygenating, providing adequate state of tissue perfusion, and then off-gassing through diffusion, right, to allow deoxygenated blood, okay, this would be our carbon dioxide waste removal, to be exhaled back in the alveolar area. If we have an inadequate state of this perfusion in the tissue cell, what happens? One word, what happens? Inadequate state of tissue perfusion, what happens to the patient? Death, right? So they go into what? Yep, shock, exactly. Inadequate state of tissue perfusion is shock. Awesome. So, in the presence of oxygen, the mitochondria of the cells convert glucose into energy using a process known as aerobic metabolism. Okay. So energy from the ATP, which is adenosine triphosphate, is produced through the Krebs cycle and oxidative phosphorylation. I'll do it up a minute. So anaerobic metabolism occurs when oxygen is not present and cannot meet the metabolic demands of the cell. All right. With that, glycolysis then results with less ATP production. So adequate levels of perfusion and external ventilation must be present for aerobic internal respiration, right? So there may be a time where we have to ventilate this patient. So if a patient's alert but can't control their breathing, and they're breathing 50 times a minute, what can we do to assist them?
BVM?
BVM, exactly. Control that rate, right? Get them down to where they need to be. So neural control originates in the brainstem, in the brain. The primary control comes from the medulla and the pons. The medullary respiratory centers control the rate, the depth, and the rhythm of breathing in a negative feedback interaction within the pons. The apneutic center of the pons is a secondary control center if the medulla fails to initiate respiration, then our backup then takes over. The pneumotaxic center has an inhibitory influence on inspiration. Respiratory rate then results from the interaction between the apneutic and the pneumotaxic centers. So in times of increased demand, the pneumotaxic center decreases its influence in hopes that this will neutralize the system and be able to breathe normal. Then we have chemical stimuli along with this as well. So the chemoreceptors modify rate and depth of the respiratory drive. They constantly monitor the chemical composition of body fluids. The central chemoreceptors monitor pH of the CSF and are located adjacent to the respiratory center, in the medulla. An increase in the acidity of CSF triggers the central chemoreceptors to initiate the rate and depth of respiration, right? So what would cause the patient to have an increase in acidity?
EKA.
Right? Decreased respirations, increased carbon dioxide. So like Matt O'Connor just said, right? We have a patient that's decreasing respirations, going into a Brady type respiratory drive, will therefore increase the end-tidal CO2 readings, like the 50s to 60s, elevated higher than our normal 35 to 45. At that point, it will trigger the central chemoreceptor to increase the rate and depth of the respiration. So George, like you were talking about in DKA, a patient in Kussmaul respirations. I didn't want to blow you off. I just wanted to get to that point. Right? So we're starting to see that rapid and then that slow, then that deep respiration, then that rapid, because our body's trying to blow off all those gases within the system of patients in diabetic ketoacidosis. Right? So chemoreceptors are located in the aortic arch, and the carotid bodies also respond to decreased PaO2, right, which is a backup to the primary control of ventilation. So when serum carbon dioxide or hydrogen ion levels increase, chemoreceptors stimulate the dorsal and ventral respiratory groups in the medulla to increase respiratory rate. Right? So all this stuff is happening within the system, and our body is measuring that pH in the CSF and in the blood to say, hey, we need to move forward and help this patient ventilate, oxygenate, and we can do that by monitoring end-tidal and SpO2 and just looking at their signs and symptoms the way they present to us. All right? Does that make sense? Okay, perfect.
Yeah.
So the second part of chemical stimuli is the dorsal respiratory group is then responsible for initiating inspiration based on the information received from the chemoreceptors. So ventral respiratory group is primarily responsible for motor control, of the inspiratory and expiratory muscles. So if we have an injury to what part of the body, what can really throw all this stuff up? What runs all this?
The brain.
The brain, yeah. And follow the brain down to what? The spinal cord, right? We have to be able to run our central nervous system that helps control all of this. That's why it's so important to follow the basics. Cervical collars save lives. One turn. C3, C4, and C5 keep the body alive. It controls everything, our respiratory drive, everything, right? So if we have fractures in those and it severs the spinal cord, we can't ventilate, we can't oxygen, we can't breathe, we can't function. Okay, that kills people. Right? That's why it's so important to make sure we're holding C-spine. I mean, I guess this is not a trauma class, but understanding that. This is why we put collars on patients. This is why we do what we have to do with backboards, the scoop stretchers, keeping people still. Right? Because any simple move could cause that to change. All right. So pathophysiology of respiration. Disruption of the pulmonary ventilation, oxygenation, and respiration will cause immediate effect on the body. Immediate effect. any kind of disruption. So hypoxia, so tissues and cells of the body that do not get enough oxygen. The hypoxic drive then stimulates breathing when arterial oxygen levels start to fall. Right? We're not looking at blood gases. We don't see them. We don't do arterial blood gases in the field. If you're doing an interfacility transport and they've had a respiratory patient, ask them if they have one and talk to respiratory about it and have them explain it to you. Right? Because that's going to help you determine how we're going to treat our patient during the transfer. Right? But we can tell hypoxia. We have oxygenate. We can look at the patient's skin color and temp, the respiratory rate, their heart rate, pulse oximetry, good pleth, end tidal. We can tell if someone's hypoxic the way they even look. The less sensitive and powerful than the carbon dioxide sensors of the brainstem, typically found at end-stage COPD. The onset and degree of tissue damage caused by hypoxia often depends on the quality of ventilation. Right? Quality of ventilation. We can change that degree of tissue damage from hypoxia if recognized early, okay, and we start treating it with ventilation. Right? Early signs of hypoxia include restlessness, irritability, apprehension, tachycardia, anxiety. Those are early signs of hypoxia. You notice how I didn't say cyanosis? You notice how I didn't say a weak, thready pulse, right? Because those are late signs of hypoxia. Mental status changes, a weak, thready pulse, cyanosis. Responsive patients will report shortness of breath, dyspnea, and may not be able to talk in complete sentences. This is what we call word dyspnea. And this is something that you should document in your documentation, in your narrative, on how many words they can speak before they have to take their next breath. Administer supplemental oxygen before signs and symptoms of hypoxia appear. If they say they're short of breath, give them oxygen. Never withhold somebody oxygen if they say they're short of breath. I don't care if their oxygen levels are 99%, because that could be a false positive. Patients that have carbon monoxide in their system, or patients that are anemic, can have high readings of pulse oximetry and have that not be accurate. So the ventilation perfusion ratio and mismatch, we're talking about the VQ mismatch, is to exchange gas by simple diffusion, ventilation, and perfusion that must be matched. Failure to match ventilation and perfusion, the VQ mismatch, contributes to most abnormalities in oxygen carbon dioxide exchange. Again, end tidal versus pulse oximetry. When ventilation is compromised but perfusion continues, blood passes over the same alveolar membranes, without gas exchange taking place. In a result of inadequate perfusion is less oxygen absorption in the bloodstream and less carbon dioxide removal, causing a patient to go into shock. That's why it's so important to monitor this stuff all the time. Oxygenation, pulse oximetry, ventilation, end tidal CO2, capnography is a basic level skill in New Hampshire. It's BLS. Put them on the patients. It's within your scope of practice in New Hampshire to do so. Right? Yeah, there is a cost, right? And I have yet to see any service chief say to me, well, we don't want to use it because it's too expensive. Use it for patients that you need to monitor. Not every patient needs it, but most patients actually do. So factors affecting ventilation. Many intrinsic or extrinsic factors cause airway obstruction, right? So there was interruptions to the central and peripheral nervous system also have an effect on the ability to breathe efficiently. Hypercapnia, high levels of carbon dioxide, overall increases of carbon dioxide levels in a bloodstream. Hypocapnia obviously would be low, right? Trauma to the head and spinal cord can also interrupt nervous control of ventilation. Muscular dystrophy causes degeneration of muscle fibers, slowing motor development and loss of muscle contractility. Right? Patients with allergic reactions might have swelling, angioedema, swelling of the tongue, and experience a decrease in pulmonary ventilation from bronchoconstriction. So what do we do for a patient in anaphylaxis?
Epinephrine?
Yeah, epi, but what's the dose? What's the mixture? How do we give it?
We give 1 to 1,000, I believe, and it's IV
Not
or
IV, go to the other one.
IM.
Yep, intermuscular, perfect, right? And then what else can we do? Give them a neb. Bronchodilate them. Intramuscular epinephrine, bronchodilation. Everybody always sticks with epi. Yes, epi is amazing. Vasoconstriction is a great thing. Okay, it helps reduce everything. It reduces angioedema. It helps reduce any kind of interswelling, right? Reduces that kind of stuff. We don't have the ability as AEMTs to give Benadryl, but we also want to bronchodilate, allow for that oxygen to get in from that allergic reaction, right? So give them that albuterol treatment, that duoneb treatment. Give them that intermuscular epinephrine for anaphylactic patients, right? Then call for the paramedics so they can give other medications as well, right? Patients that are that bad of anaphylactic reaction, right, where they have angioedema, they also may need to be intubated. They also may have to have an epi drip started if the epinephrine intermuscular injections are not working. The medics have the ability to do epinephrine drips to continue that. But again, you have that ability at the A level to do this, right? IM, epi, bronchodilation, albuterol. Intrinsic factors include trauma and foreign body airway obstructions. Respiratory splinting can also result in a decreased pulmonary ventilation as well. So patients that have trauma tend to respiratory splint, you want to call it, by not taking deep enough breaths, which then can affect that ventilation. Hypoventilation or slow breathing will carbon dioxide production and then will exceed the body's ability to eliminate it, which will see that high number, right? Hypoventilation, high number in carbon dioxide, right? Where carbon dioxide elimination is depressed to the extent that it will no longer keep up with normal metabolism. Hyperventilation or rapid breathing, carbon dioxide elimination exceeds the carbon dioxide production, and therefore you'll have a lower carbon dioxide reading on end tidal. Hypoventilation and hyperventilation could represent the body's attempt to compensate for various abnormal conditions, like alkalosis, high pH in the blood, or acidosis, low pH in the blood. So decreases or increases in minute volume can result in problems with carbon dioxide levels within that system. So looking at this, everything we've covered so far, we're going to take a 10-minute break. Been doing this for an hour. What have we covered that's important? Other than all of it. I get all of it's important. But what's important to us right now? I've been saying this all class. What's important here? Anybody?
BLS?
BLS, and what two things are so important to make sure a patient is doing? Right? One, getting a good patient assessment. 2 words: oxygenation, ventilation. Oxygenation, ventilation. The 2 most important things you can monitor with a patient assessment is, are they oxygenating and are they ventilating? If they're not ventilating, we got to fix it. If they're not oxygenating, we got to fix it. At the A level, we carry CPAP and meds to help fix a lot of those problems. What do we need to do to make sure they are oxygenating and ventilating? All right. So with that being said, let's take 10 minutes. We'll come back at 7:18 and we'll move forward to the next hour.
This conference will now be recorded.
Wrong button. All right, so let's talk about factors affecting oxygenation and respiration again. So as you can see, a lot of this is really based on oxygenating and ventilating. So some of the external factors, obviously with attachment of carbon dioxide molecules to the hemoglobin molecules, can also provide a false oximeter reading, which we talked about before. Internal factors that could also have an effect on oxygenation would be conditions that reduce the surface area for gas exchange, like pneumonia, pulmonary edema, or fluid in the lungs, or COPD. Anemic patients can also have a factor as well on showing good oxygenation. Why would anemia play a factor in that?
Not enough red blood cells
Yeah,
to show adequate representation of how much oxygen's attached to them.
that's perfect, Tondra, exactly. All right, so other things we look for is other factors would be non-functioning alveoli or non-functional, intrapulmonary shunting, changes in respiratory rate, pain and strong emotions, decreased metabolism, and other conditions including hypoxia, hypoglycemia, and infection, like sepsis, or without insufficient glucose, the cells will metabolize fatty acids, resulting in a ketoacidosis. Circulatory compromise can also affect this as well, which leads to inadequate perfusion, obstruction of blood flow to the individual cells and tissues related to trauma. Other conditions you may encounter is a pulmonary embolus, a simple or attention pneumothorax, an open pneumothorax, a hemothorax, or a hemopneumothorax. So blood in the lung or blood with a collapsed lung. Heart failure and cardiac tamponade, which will also inhibit the ability of the heart to effectively pump. Hemorrhagic shock, blood loss and anemia, vasodilatory shock, aggressive treatment, or oh my goodness, aggressively treat any patient suspected in being in shock to prevent further interruptions in tissue perfusion. Now, we can talk about vasodilatory shock, which would be what? What could cause that? What could cause widespread vasodilation and shock?
Heat,
Anybody else?
like a heat stroke.
Okay, what else could cause a massive vasodilation? Any thoughts, anybody? Massive vasodilation from bacteremia. Bacteremia would be caused by
An infection?
an infection. Yeah, exactly. An infection. So bacteremia caused by infection, causing vasodilatory shock. So vasodilation widespread would be a patient who is septic.
Septic.
That's it. Sepsis. One of the most missed diagnoses in the field from all levels of providers is missing the classic signs of sepsis. Right? There are so many new studies that are out there, and I just listened to a critical care study that was phenomenal on hypertonic versus isotonic solutions on how we treat patients. All right. So it's amazing some of the new studies that are coming out with sepsis treatment. But right now, one of the best treatments that we're seeing is the mixture of back and forth of lactic acid, lactated ringers, and normal saline. But these patients, in all reality, they're getting 7 or 8 liters of fluid to help with that widespread vasodilation. And some of them are actually going on pressors, right, to help bring that blood pressure back up with multiple different antibiotics being given to stop that infection, right? And one of the most common infections in the body that causes sepsis is pneumonia. respiratory, another airway issue that's causing this. So as you can see, simple things like this of airway inability are turning into widespread sepsis that's killing patients, right? Putting these patients into shock. And we're talking about airway management. Here we're talking about patients that have vasodilatory shock. It's amazing, right? Septic patients, bacteria, pneumonia, simple pneumonia turning into a sepsis, causing a patient to have multiple organ dysfunction or MODS, or even going as far as getting DIC. It all turns into one big mess, right? One big mess of a patient, sick patients. These patients are getting intubated and everything else to protect that airway to help ventilatory status and oxygenation status because of that widespread vasodilation. We're looking at, vasodilatory shock. Other acid-base balance stuff. So disruption for hypoventilation or hyperventilation causes disruptions in the acid-base balance. So that may result in a rapid deterioration and death with this. So excessive acid can be expelled as carbon dioxide from the lungs. Slowing the respirations will increase the level of carbon dioxide. So now we're becoming Brady, and now our carbon dioxide levels are going higher, getting that higher end-tidal reading. So the fastest way the body can eliminate the hydrogen ion acidosis is to create water and carbon dioxide, right? So now we start seeing that potential rapid removal. Anything that inhibits respiratory function can result in acid retention and acidosis, right? So if we're breathing too low, we see that retention in acid with a higher end-tidal reading. So acidosis can be caused due to low respiratory rate or tidal volume. Patients that are alkalotic can be caused from a high respiratory rate or tidal volume. So there are four main clinical representations of acid-base disorders: respiratory alkalosis, respiratory acidosis, metabolic acidosis, metabolic alkalosis. Okay? So this fluctuation in pH due to the availability of bicarbonate levels result in a metabolic acidosis or alkalotic issue. Okay? Fluctuations in pH due to respiratory disorders result in respiratory alkalosis or acidosis. The treatment for the classic hyperventilation syndrome focuses on restoring the normal respiratory rate to increase the carbon dioxide level, getting that rate back up to normal between 12 and 20 breaths a minute. Now, that was a lot of talk, right? There are things you need to know that to help with this. All right, so I'm going to give you some numbers. If I can type, let me type it in anyways. Stand by a minute. I want to type this in for you guys. Let's see. End-tidal CO2 is 35 to 45, normal range, right? Okay, here's another one for you here. I just put up on the chat box. HCO3, bicarb, 22 to 26. Okay, pH, 7.35 to 7.45. Those are normal values, okay? Everybody following?
Yes.
Okay. Now, look at those numbers again, okay? See a lot of yup and yups. If the end-tidal is high and our pH is high, or end-tidal is off and our pH is high, it's a respiratory issue, okay? So it would be respiratory alkalosis. If our bicarb is off and our pH is high, it's metabolic acid alkalosis, okay? So if there's a bicarb issue with a pH change, and the pH is elevated, it's alkalotic. If the pH is lower, it's acidotic. If it's a bicarb issue, it's metabolic. If it's a respiratory issue, it's end tidal changes. Does that make sense? This is the easiest way to learn acid-base balance. Look at these three values, and if it's elevated or decreased pH, acidosis, alkalosis. If it's off because of bicarb, it's metabolic. If it's off because of end tidal, it's respiratory. Does that make sense?
Yes.
On Sunday, I will show you guys the tic-tac-toe method of acid-base balance. I can't show you on here, but I will show it to you on Sunday during class, all right, when we meet in person this Sunday. I will take out a tic-tac-toe board. We'll play tic-tac-toe with these numbers. I'll show you an easy way to remember how to do this in the field. All right? Good, good. Let's move forward then. All right, so patient assessment airway evaluation. Recognizing adequate breathing. Breathing should appear easy, not labored, with normal respiration between 12 and 20 breaths a minute for the adult, with adequate depth, tidal volume, regular pattern of inhalation, exhalation, so normal eupnic breathing, okay, clear and equal bilateral breath sounds. Equal rise and fall, clear on both sides, bilateral in all fields, listening to all the lobes. That's a normal breathing. So we have to be able to pick up on the inadequate stuff. So an adult patient who is breathing at a rate of fewer than 12 breaths a minute or more than 20 breaths a minute should be evaluated for other signs of inadequate breathing. Why are they breathing too fast or too slow? Patients with respiratory distress often compensate with preferential positioning. So where do they prefer to be as far as sitting down, standing up, or whatever they feel is better for them? Respiratory distress may be the result of an upper or lower airway obstruction, inadequate ventilation, impairment of the respiratory muscles, impairment of the nervous system. We've got to do a full body assessment. Why is this happening? Dyspnea is a difficulty in respiratory rates, regularity, or efforts, which may be a result of hypoxemia or low oxygen in the blood. Untreated hypoxia will result in anoxia and death of the body's cells and tissues. Okay, we have to make sure they are being oxygenated. Skin color and temperature can tell you a lot about a patient being in shock. All right. So evaluation of the patient in respiratory distress includes observations, palpation, and auscultation. Look, listen, and feel. Touch your patients, palpate them. Listen to the lungs. Look at how they present to you. How is the patient positioned? Is the patient in tripod, elbows out? Does the patient be experiencing positional dyspnea? Right? Is there adequate rise and fall of the chest? Is the patient gasping for air? What color is their skin? Is the skin moist or clammy? Are they not being perfused? Is there flaring of the nasal or the nares present? Nasal flaring. Is the patient breathing through pursed lips? Right? Pursed lips create PEEP. If everybody in the class right now were to take a deep breath in and out with their mouth wide open, you'll notice the air goes in and out really fast. If you did it again with pursed lips on exhalation, you'll notice it takes longer for your lungs to deflate. That's PEEP. That's why you get pursed lips. If you know any retractions, skin pulling around the ribs during inspiration, intercostal issues, any kind of intercostal muscle use, at the suprasternal notch, at the subclavicular fossa, supraclavicular fossa, sorry. or any subcostal muscle use. Is the patient using accessory muscles to breathe? Right? Is the patient's chest wall moving symmetrically in and out? Is the patient taking a series of quick breaths followed by a prolonged exhale phase, like DKA? Okay. What is going on with your patient? The patient with inadequate breathing may have labored breathing. Note that. Accessory muscles are not used during normal breathing, as you can see here in this photo. Sternocleidomastoid, pectoralis major being rectus abdominis, accessory muscles being utilized to help breathe. That's not a good sign. These patients here are in severe respiratory distress. Right? Signs of inadequate breathing in adults are also respiratory rate of fewer than 12 or more than 20, an irregular rhythm, diminished or absent or noisy auscultated breath sounds, abdominal breathing, reduced flow of expired air at the nose and mouth, unequal or inadequate chest expansion. Put your hands on each chest, underneath the breasts of a female or pectorals of a male. Spread your fingers apart and have them take a deep breath in and out and feel that expansion. Make sure they're equal on both sides. Don't just look, you have to touch your patient. All right? Increased effort of breathing. Shallow depth. Is the skin pale, cyanotic, cool, mottled, or moist? Clammy. Are there any retractions? Are there any staccato speech patterns? Pay particular attention to the external environment. So auscultate the breathing. Listen to lung sounds. Feel for the air movement around the mouth and nose. Observe the chest for symmetry, and also note any paradoxal motion. So the chest going up and down, opposite. Evaluate as well as assess the history of the present illness. Okay. Look for pulsus paradoxus. Note the protective reflexes of the airway and modified forms of respiration, such as sighing or hiccuping. Right. Another one to look for too is serious head injuries may also cause irregular, ineffective respirations that may or may not have an identifiable pattern, like ataxic respirations, or as you can see in the slide, Shane Stokes breathing. As you can see, rapid breathing to none, to rapid breathing to none, inspiration, expiration. Pay attention to this, right? Indications of head trauma. Agonal gasps, and be vigilant when monitoring patients in respiratory distress. So, as far as the assessment of the respiration goes, a patient's level of consciousness, LOC, all right, and the skin color are excellent indicators of respiration. Look and see what they look like, right? When treating patients with altered mental status, always consider the possibility that patients may not be getting adequate oxygen to the brain. What does their skin look like? What does their pulse oximeter look like? What does their end tidal look like? When treating patients with an altered mental status, always consider that. Determine the baseline mental status of the patient. So if they already have dementia, what is baseline for them? Are they always confused, right? Or they normally alert-oriented, CAO times 4, the GCS of 15, and now they're confused. Why, right? Consider the proper oxygenation when assessing the patient, looking at pulse oximetry, and what remember is a non-invasive method of measuring how well a person's hemoglobin is saturated. Okay, hemoglobin being saturated, but it doesn't tell you it's saturated with what, right? So you have to do more of an inspection. To ensure that the instrument is measuring arterial and not venous blood saturation, SpO2, pulse oximeters are designed to assess only pulsating blood vessels. So the functionality can be checked by comparing the pulse reading with a measurement obtained by palpation. So you look at the pulse or look at pleth, and each pleth wave should be your heart beating. You should be able to feel a radial pulse. So situations in which the pulse oximeters may be useful would be monitoring the oxygen status of the patient during an attempt to insert an advanced airway or during suctioning, identifying deterioration in the condition of a trauma patient, identifying deterioration of a condition in the patient with cardiac disease, identifying high-risk patients with respiratory conditions, assessing vascular status in an orthopedic patient or trauma. Circumstances that might produce erroneous readings would be a bright ambient light. That's why you always want to make sure it's dark. Patient motion, poor perfusion, nail polish, venous pulsations, and abnormal hemoglobin. So in patients that are anemic. So do not make any treatment decisions based solely on pulse oximetry. Look at pulse ox, look at end tidal, look at your skin color and temp, your vital signs, and a good patient history. And that's how you're going to make a determination on how you're going to treat, not just off a monitor, not off a tool. All right. So peak expiratory flow measurement, okay, helps prevent bronchial constriction. Right? You'll see this kind of stuff with patients coming out of hospitals that came out with like pneumonia, things like that, or any kind of respiratory type surgery. Maybe put on these peak flow measurements to kind of help with that. So increasing peak expiratory flow suggests that the patient is responding to treatment. We do not check those in the field. We do not carry them on the ambulance. Decreased peak expiratory flow may be an indication of deterioration. Varies based on sex, height, and age. Okay, so again, that's why we don't carry these in the truck. Perform the test 3 times to make the best peak flow rate of these 3 readings. The arterial blood gas analysis, or what they call an ABG, provides the most comprehensive quantitative information about the respiratory system. Right. So if you look in your books on table 11.6, the normal ABG values are summarized there. Very good information to know. SaO2, SpO2, PO2. They'll have your pH, bicarbonate. Everything's all there for you. Everything you need to know about the respiratory system. That's why it's so important to be able to know how these look for normal values. End-tidal carbon dioxide assessment detects the presence of carbon dioxide in exhaled air. Also, these types of monitors include colorimetric, digital, and digital waveform. Colorimetric are the ones that just change color from yellow or purple to yellow. Yellow is good, purple is bad. Purple means there's no carbon dioxide. Yellow, yay for yellow is good. We don't have a ton of just digital only, and the ambulances, our cardiac monitors are designed for digital and waveform, right? So they both play an important part with that. So the colorimetric carbon dioxide detectors provide qualitative information regarding the presence of carbon dioxide in a patient's exhaled breath, as you can see utilizing on a BVM. They're sensitive to extreme temperatures and humidity, so they can not work, give you false readings of that. They're less reliable if a patient vomits or secretions get inside of it. So the paper inside the device degrades over time, so the capnometer provides quantitative information in real time by displaying a numeric reading of exhaled carbon dioxide levels, as you can see in the second picture here, the end-tidal CO2. It gives you a better reading of number of where we sit, but the best thing to have is the capnograph, as you can see here. So with this provides a graphic representation of exhaled carbon dioxide levels. The waveform capnography provides quantitative, real-time information regarding the patient's exhaled carbon dioxide. So, patient takes a breath in, drops down to 0. As they exhale, you have that quick upshoot going up, and then this is what they call the plateau coming across. And that little circle you see here, that is your end tidal reading before the inhalation going back down to 0 again. The number you're reading on the meter, if it goes right through like this here, it would be around 38 or so. That's your end tidal reading, 38. This, what you see on the screen, is a normal waveform, right? Any questions at all so far on this? Good? No? Right? Very important to understanding how these work. I have a whole other lecture that I do just on capnography, because there's so many different rhythms and waveforms that we can look for to be able to tell how a patient's presenting. So there's 2 different ways to measure this. One would be through a nasal cannula. So that orange device here screws into your monitor, whether it be a life pack or physio, life pack. Zoll X series monitor, whatever it may be, right? And the other side of this right here is for your oxygen you get through nasal cannula. Now, let's say the patient needs more oxygen than the nasal cannula. Leave that in place and put an underbreather over it, right? So we can still monitor that end tidal reading. The same thing with CPAP. Have this in place. The bottom one is what we call a mainstream. Okay, this is an indicator of effective chest compressions and ROSC. You can place this in a BVM as well to be able to get accurate readings. You just got to make sure you have a good seal. The other option with this as well is also utilizing, not an option, but it's required, if you place an intubation tube or a supraglottic airway like a King airway or an iGel. These are required to be in place to be able to tell you good placement and that you're ventilating a patient appropriately. And this will also tell you if you're getting good compressions. They mentioned ROSC as well with this here. So ROSC, you'll have an increase in end tidal minutes before you get pulses back. So if you see a patient that you're doing compressions on and you're ventilating and their end tidal is sitting around like 15 to 20 and it spikes to like 60, when you're done with your round of compressions, check for a carotid pulse because most likely you'll have a pulse at this point. Instantaneous. All right, so opening the airway. To open the airway and assess breathing, patients need to be in a supine position. All right, position the unresponsive patient. There's skill drills within your book that you can look at. Which, by the way, I will have all the books that I have left over here for the 30th for class. If you haven't received one yet, I will have those books for you. The head tilt chin lift maneuver. I don't think I need to go in this in depth. This is all BLS. If anybody doesn't understand head tilt chin lift, everybody good with that? I hate all of you. All right. Jaw thrust maneuver used for trauma patients. All right. So the tongue jaw lift maneuver, not used very often, but you can reach into the patient's mouth and hook your first knuckle underneath the scissors of the gum line and pull. I'm not a big fan of putting my fingers in anybody's mouth unless I absolutely have to. Yeah, Hulk break jaw. Yeah, I probably would. So let's not do that. Again, methods that you can utilize, just be very careful. I agree, Tondra, no desire to be bitten by a patient. All right, so maintaining the airway, once we have, if it's not a traumatic injury, we turn them on to their left side, what's called left lateral recumbent position, as well as what they call a recovery position. Over there, it maintains their airway to be open. We can utilize suction as well. Remember, suction is first priority. What you're seeing here is a hand suction, or what they used to call back in the day VVACs. They were yellow. Some of the main sources may actually still have those on the trucks, but they're old school. These are more the newer style now. We have the in-house suction here. Again, there's portable hand operated, battery operated, and fixed mounted. Your fixed mounted ones are all going to be located in your trucks. We do have the portable suctions as well, like you can see here. You want to make sure that you're testing these, and they kind of bring back some memories of those of you who went through EMT school a long time ago. You want to make sure, and this is testing on your testing phases, 30 seconds at 300 psi. That's to maintain. So you fold your tube and check it. There are different types. The wide bore, thick walled, and non-kinking tubing you have to have. There's soft and rigid, rigid being Yankauer, soft being French tip catheters. Yankauers come in one size for the ambulance. The French tip come in different sizes from like 10 French to 15, or sorry, 16 to 18. They go in even numbers based on the size, thickness you're going to be utilizing. All right. We all know how to use suction, I'm hoping, at this point in time. Right? A suction canister is hollow and cylindrical device to use to remove fluids. Imagine that, right? Right, perfect. Let's go through all this stuff here. Let's see. So again, when suctioning a patient, Okay, you have to test it to meet more than 300 millimeters of mercury, and then select and attach the appropriate catheter. So if we're intubating a patient or putting a supraglottic airway in a patient, we want to use a French tip catheter to go down that to be able to suction out if we need to. Limit suction time for 15 seconds to adult, 10 for children, 5 for infants. Remember that we are pulling oxygen out of these patients. Okay. So again, you will be tested on airway management and the simple stuff is of using suction and everything else like you did for your EMT testing. As far as an ET tube goes, you may be asked to assist with this. So tracheobronchial suctioning of an intubated patient. You just basically take the tube before holding your thumb over this here. I don't know why he has it in the picture. What you want to do is sit the tube down inside the suction tubing down through the intubation tube and suction on the way out, pulling the fluid out. These patients here should be pre-oxygenated as well. So if you're ventilating, we're going to pre-oxygenate by giving a little bit more oxygen or hyperventilating shortly, and then we can suction out afterwards. These are oropharyngeal airways. They are not to be placed in a patient who has a gag reflex. Measured from the corner of the mouth or the corner of the jaw, inserted in a, so this end here hits the soft palate, spun 180, and then goes into the airway. This is a nasopharyngeal airway. Can be used for the patient who has a gag reflex. But let me ask you this, when is it contraindicated on a patient?
Head injury.
Yep, specifically what type of head injury, what kind of fracture? Or a facial injury. Give me a fracture where it's contraindicated.
Nasal, anything, yeah, anything
Yeah.
nasal related.
Otherwise, I got orbital blowout. So I got the brain, right? How about a basilar skull fracture? Yep. So how do we tell if a patient has a basilar skull fracture? Raccoon, not raccoon eyes.
Battle wounds.
What was that?
They call them battle wounds.
Battle signs behind the ears. Yep, battle signs. So raccoon eyes are for your orbital fractures. So battle signs. Yep. All right, perfect. We already covered all that too. Moving forward. So this is oxygen. I'm sorry, guys. This is oxygen. This is the oxygen cylinder.
Wow, really?
Yeah, imagine that, right? Next. All right, so liquid oxygen is oxygen that is cooled in an aqueous state. Larger volume of oxygen can be stored with these containers, and they don't have to be. They need to be filled as often. So some safety considerations with liquid oxygen would be to ensure correct pressure regulators are firmly attached before transport. Puncture a hole in the tank and cause the cylinder to become a deadly missile. Go through concrete walls, kill people. Bad things happen. All right. So as you can see, this pin indexing system that's here prevents the oxygen regulator from being connected to a different gas cylinder. There's pins located everywhere and make sure they actually fit appropriately. Now, I know in Maine for a while, I think they are, for those of you who still work in Maine, we don't have separate regulators. A lot of the oxygen bottles I've seen in Maine have integrated regulators now. Where in New Hampshire, I see a lot of the ones still have the separate regulators. The biggest thing to make sure you have on there is your high pressure ports are still located there. Some CPAP devices require high pressure ports. Let's see, pressure regulators. There are two-stage regulators reduce pressure first to 700 psi, then down to 40 to 70 psi, and the final attachment for delivering gas to a patient with a quick connect female fitting or a flow meter. As you can see here, this is a flow meter for the wall. This is a flow meter regulator for a bottle. You'll notice that when you apply this, you have the device that spins into the side of the bottle to hold it in place. You have a yellow or some type of gasket. Now, some bottles now are coming with pre-built-in gaskets. You don't have to change out. Some you do. So again, be familiar with the service ones that you guys have in place. All right, so kind of go through those. To operate a flow meter, you open it up to your desired flow rate, whether it be 1 to 15 liters per minute. When you are all done with that, make sure you turn off your bottle and drain out all your oxygen. Any questions on how to use an oxygen bottle?
I'm gonna say no.
I would hope so at this point, but you never know. I'm always here for any questions.
Wait, which end is up again?
Oh boy. So hazards of supplemental oxygen, guess what? It supports combustion, right? So that's a bad thing. How many times have you guys been to a patient's house before where they lit their face on fire, right? Because it supports combustion. It's not flammable, it supports it. Oxygen toxicity is actually pretty bad, which is why we don't want to bring oxygen levels to 100%. We want to keep around 98 to 99. So damage to the cellular tissue as a result of excessive oxygen levels in the blood. So tailor oxygen therapy to the patient's needs and use caution with administration, right? Current evidence suggests that increased cellular oxygen levels contribute to the production of oxygen-free radicals, okay? That's bad. We do not want oxygen-free radicals in the system. It will actually kill somebody. Oxygen toxicity is a thing, right? So there are different delivery devices. There's something called a non-rebreather mask out there, which would be a mask with a bag below it that you want to fill between 10 to 15 liters per minute, which provides 90% oxygen. You have your bag valve mask, which is a mask that goes over the patient's nose and mouth, providing 100% oxygen, and you have nasal cannulas that run between 22 to 44% oxygen, okay, when you start it from 1 to 6 liters. So non-rebreather mask, 90%, okay, at 10 to 15 liters per minute. Bag valve mask, 15 liters per minute, 100% delivery. Nasal cannula, 1 to 6 liters per minute with a 22 to 44% delivery, right? The non-rebreather mask is the preferred device in the pre-hospital setting because the book says so. Contraindications include apnea or poor respiratory effort. If they are not breathing, this is the whole difference between oxygenation and ventilation. Just because the pulse oximetry is 60%, you can throw them on nasal cannula or non-rebreather and bring stuff up, right? It does not mean that they are ventilating appropriately. This is why oxygenation and ventilation go hand in hand, right? They have to perfuse. And if they're not ventilating appropriately, they're not going to perfuse, no matter how much oxygen you give them through a non-rebreather. A person in cardiac arrest, you throw them on a non-rebreather, what's going to happen? Nothing. Nothing until you start compressions. You have to have perfusion, right? Perfusion has to happen. Can't stress that enough. So here's a non-rebreather mask. This is what it looks like. It's got a tubing here, a mask here. Sometimes it has one-way ports on each side with like rubber pieces over them. You can take those off, it doesn't matter. This bag has to be full of oxygen. Do not overfill them as they do pop and scares the hell out of your patients. All right. Now, if your patient is sucking this thing down at 10 liters a minute, control their respiratory drive and increase your oxygen levels just a little bit so they don't suck the bag down dry. This is a nasal cannula. It goes into your nose. Please make sure that when you apply the nasal cannula, that the angle of the actual cannulation stuff here is going in the right direction, not aiming upwards towards the nose. Yes, I will talk about that shortly. Right? This is a oxygen delivery device called a partial rebreathing mask. Right? We are not really using those in the field. Venturi masks as well. Right? We don't really get into those. They're not really used. But the medium flow device runs between 24 to 40% oxygen depending on the manufacturer. So again, This kind of assists you with a little bit higher flow of oxygen, but doesn't really hit that non-rebreather mask. A little more tolerable on a patient's face. This is a trach mask, as you can see in the photo here. The special mask that goes over the over the trach to provide oxygen. Now, if you don't have one on your truck, or you use the last one because you get 15 calls a day for these, right? You can use a non-rebreather and put that over the top of the mask, and it will work perfectly fine. Right? You can modify. Jen, I have not forgotten about you yet, so give me a minute. I'll get back to the non-rebreather versus CPAP in a moment. Right? Then you have oxygen humidifiers, usually indicated for long-term therapy. Right? Some ambulance services I've worked for in the past have had these in the truck. I've never pulled one out and used one before. It's a rare case where I need to use one in the back of an ambulance. Well, this is humidified oxygen. Now, there was a service that I worked for in the past. And Justin, you're on here still, right?
I am.
Right. So Lebanon used to have a heated, humidified oxygenation system. Okay, it used to be an orange. It was an orange box kept in one of the ambulances years ago when I worked over there a long time ago.
It's sitting at the soon-to-be former Station 2 in a closet.
Yep. So that was utilized for your hypothermic patients that needed oxygen. And it actually heated the system up pretty nice. It's actually a good device. And I'm not going to name drop it during this lecture, but I know who put it on the truck many, many, many years ago when I started working there in 07. That's when they were putting it on the ambulance. So that was a while ago. But maybe it was 06. I don't remember. One of those 2 years. With that being said, there are other methods that are out there to be utilized. But that was the only service I ever worked for the many that I've done time with, that ever had a heated, humidified oxygen system. So artificial ventilations, utilizing a BVM or assisted, provides 100% supplemental oxygen. Other systems would be CPAP. So now let's talk about CPAP, Jen, for a minute. So you're asking the difference between the two. Okay, so a non-rebreather does not provide any pressure. It just provides oxygen at 90%. That fills into a reservoir bag. So when you take a breath in, it sucks in that oxygen from the bag, right? But it's not a fully sealed system, right? CPAP is continuous positive airway pressure that continuously pushes, has pressure, positive pressure going into the airway, into the lungs, but also provides something called PEEP. Because that pressure is going in, it allows the lungs to stay open for a longer period of time to allow for the alveoli to oxygenate the system better. Okay, and you can set your PEEP from 5 to 15 based on New Hampshire protocol. Right, so the higher the PEEP, the longer the lungs stay open. Were you there the other day when I was messing around with the vent with PEEP, Jen? Okay, that's what PEEP was doing. When I was blowing that glove up to like ready to explode. I was showing you guys the difference with PEEP pressures and all that. So that's PEEP. That's what CPAP will do for somebody, right? The only difference is I had it in BiPAP mode, but I was just messing around testing it out. So that's what PEEP does. That's the difference between CPAP and a non-rebreather, right? Non-rebreathers help oxygenate. CPAP will help with that ventilation as well, because it keeps it open. So you do not need a special machine to run CPAP. CPAP is a disposable device. So all the action trucks, Jen, carry a pulmodine system on it. It's a disposable device that's in the trucks. So you can throw it away. The ventilator that I was playing with, the Z-Vent, does BiPAP and CPAP in intubated patients. And I was messing around with the vent, just doing the weekly tests I do every Thursday. So with that being said, yes, you can use CPAP on a vent, but it's also a $15,000 device for CPAP, but I can spend $60 to use it once. But BiPAP is way better for the patient because it has 2 different levels of pressure. So we'll talk about it another day. Did it help anybody else? Is that good explanation? Do you want me to go in more in depth on CPAP? Yes, you can. CPAP actually hooks into an O2 tank, providing that. All right. Yeah, I can show you. If you're in tomorrow, I'll show you. All right. I'll take one off the shelf and try it. All right. So a patient, assisting a patient with ventilation is using a back valve mask, obviously over the patient's nose and mouth. After initial 5 to 10 breaths, slowly adjust the rate and deliver the appropriate tidal volume. If they're breathing too fast, we're going to assist with that. And then we need to bring down that rate to a normal level. So as you can see, looking at this slide here, normal ventilations versus positive pressure. All right. Any questions on this slide at all? Doing okay? All right. Moving forward. All right. So mouth-to-mouth ventilations, you want to have a barrier in between so you don't suck someone's vomit into your own airway. All right. This is the device barriers. Sure, we're pretty good with all this stuff here. Mouth-to-mask ventilation is actually preferred with a one-way barrier in between if you're doing that. And then you can also have an oxygen inlet, hook in oxygen as well. This is a bag valve mask, a BVM. I'm assuming that everybody in the class has used a BVM before, whether it be on a patient or on a mannequin at least once. Except for Evan. Apparently he's sheltered. All right. Components of this would be the self-refilling bag, which is disposable, the outlet valve, one-way valve, no jam inlet valve, okay, and the volume of air is delivered based on chest rise. So if you see something on a test about BVMs, really it's all about chest rise. So we deliver tidal volume between 5 to 600 milliliters or 6 to 7 mLs per kilogram per breath will produce visible chest rise in most adults. All right, so we're good with BVMs. Let's get to manually triggered ventilation devices. So flow restricted oxygen powered ventilation devices, what they call the FROP. Right? We do not use these. They're not approved in New Hampshire. They're not approved in Maine. But they are used to ventilate apneic or hypoventilating patients. So we do discuss them a little bit, but again, nothing you're going to be tested on in either state. So with this, it has a demand valve. I'll show you guys a vent next on the next slide too. So this right here is an automatic ventilator. This is what they call the Zoll Z vent. I am very familiar with these here. These are more of a paramedic level skill. This allows variables of ventilation to be precisely set by rate, volume, and peak inspiratory time. So these are called the Z vents from Zoll. They have HT70s from Newport to LTV vents. So being proficient with all these at your level, the A level, is really not indicated. Okay, it's there. However, it is within the EMT basic scope of practice that if you get called in New Hampshire to a patient that lives at a vent facility and they are chronically on a vent, right, that is a basic level transfer, basic level, EMT, not paramedic, right? Because the patient can control their own ventilator and they're not newly on a vent. So keep that stuff in mind as well. So again, these hook into the 15-22 millimeter fitting adapters on ET tube or advanced airway devices. I've never seen them placed on a King airway before. It's either they've been intubated or they're using CPAP or BiPAP mode on these. So, and I have ventilators that I can show you guys on Sunday. All right, let's keep moving forward. All right, so CPAP increases the pressure in the lungs, opens collapsed alveoli, and pushes more oxygen across the alveolar membrane. All right, we'll finish up the CPAP part here, then we'll take a break, and then we'll finish up after that. We should be done by around 8:40 or so, 8:50, 9 o'clock at latest. The desired effect is to improve pulmonary compliance and make spontaneous ventilation easier. And it's indicated for patients experiencing respiratory distress. This is that crutch that they need. All right, CPAP is like giving somebody D50 or D10 in a diabetic emergency. It should turn them around pretty quickly. All right, it's very effective. And we'll be covering CPAP on Sunday as well. I'll show you guys what it looks like and how it works. So general guidelines on CPAP, the patient is alert and able to follow commands. If they're altered, they cannot have CPAP. Obvious signs of moderate to severe respiratory distress. If they have two-word dyspnea and satting at like 80%, they probably need CPAP. Respiratory distress after a submersion incident as well. Submersion incidents of fluid in the lungs is no different than CHFers with pulmonary edema. Push that fluid out. So Maine actually has a pretty aggressive drowning protocol, which most states do not have. Rapid breathing of more than 26 a minute and a pulse oximetry reading of less than 90. Like I said, in the 80s, they might require CPAP. Again, it's all based on the presentation that the patient needs it. Contraindications to CPAP is the patient unresponsive and unable to speak or sit up. The patient has to be in a seated position or what they call a Fowler position in order for this to work. If they have to lay supine, you can't put it on the patient at all. If they're in respiratory arrest or abdominal respirations, hypoventilation or hypotension, because of the barotrauma that can be caused by CPAP, putting pressure on the chest, can actually drop the blood pressure. So if they're hypotensive, they cannot receive it. Chest trauma, closed head injury, facial trauma, and a pneumothorax or cardiogenic shock are other contraindications as well. And last slide before we take a break. If they are in a trach, if they have a gastrointestinal bleeding, nausea, or vomiting actively, recent gastrointestinal surgical procedures, the inability to properly fit the CPAP system by mask, or the excessive facial hair as well, or dysmorphic facial features. So reassess the patient for signs of deterioration and or respiratory failure. Just because you put them on CPAP does not mean that they can't go down south more, all right? So again, the patient can still crump regardless if CPAP is on, or they might have to be intubated. So you have to constantly reassess your patient, watching your vital signs, like blood pressure, heart rate, respiratory rate, end tidal, pulse oximetry, right? All that stuff has to be watched. All right. So we're going to let's take 10 minutes. We'll come back at 8:22. All right. We'll finish up the remainder of the slides and we'll call it a night. Any questions so far?
This conference will now be recorded.
So as far as the application of CPAP goes, the patient exhales against resistance called positive end expiratory pressure. That's PEEP, which maintains pressure in the lungs at the end of exhalation and keeps the open alveoli from collapsing, right? Controlled by manually adjusting PEEP and using a manometer or predetermined by fixed setting on PEEP valve. Now, some of the devices have PEEP valves and some of the older ones used to be regulated based on the amount of oxygen going in on your flow meter. But most CPAP units are powered by oxygen itself. Every one that we're going to utilize is done by oxygen. So if you look at this as a whole, patients that maintain pressure in the lungs, right? It keeps the alveoli from collapsing by keeping that pressure open. Then we can also introduce an inline nebulizer like albuterol or Duoneb. Then there, now we keep it open and we can push that medicine all the way down to the alveolar level, causing great bronchial dilation. And that will help with an oxygenation behind that. So some patients find CPAP claustrophobic. So the best way to do it is have the patient apply the mask to their own face and hold it there. So then they start realizing it's actually working, and then they go, okay, not so bad. Then you can put it on. Possible to cause a pneumothorax as a result of the barotrauma. Also remember, it reduces blood pressure as well. And increased pressure in the chest cavity can cause a hypotension. Other considerations would be gastric distension, which is likely to occur if excessive pressure is used to inflate the lungs. Right, then it has to go somewhere else. If the lungs are already hyperinflated, then it will start going down the esophagus into the stomach, causing gastric distension, which then pushes the diaphragm upward into the chest, making it more difficult to ventilate. So some signs of gastric distension would be increase in diameter of the stomach, increasingly distended abdomen, or increased resistance in a bag mask ventilation. So things to look for. So other things to look for as well, laryngectomy would be more of a surgical procedure in which the larynx is removed, performed by making a tracheostomy or thus creating a stoma. Surgically remove the entire larynx is called a total laryngectomy. A partial laryngectomy entails surgical removal of the portion of the larynx. Artificial ventilation through the nose and mouth may still be effective after a partial. If you're suctioning from a stoma, failure to recognize and identify the need for suctioning can result in complete hypoxia. So do this with extreme care. Remember, because you are lower into the airway at this point, you are right into the lungs. So even the slightest irritation of the tracheal wall can result in a violent laryngeal spasm, causing things to close up. We don't want that to happen. So limit suction to a stoma for no more than 10 seconds at a time. And then if you look at your skill drill in your book on 11.9, that'll actually show that to you. Some ventilation procedures, perform ventilation using the mouth to mask stoma with a resuscitation mask. All right. So again, avoid techniques that involve usually using a rescuer's mouth should be avoided if other options are available, particularly in the context of an active aerosol transmission of respiratory illness like COVID-19 pandemic. Infant or child mask should be also adequately used to seal over that stoma as well to kind of help assist ventilations with that if you don't have the tubing in place. So this requires a 15-22 millimeter adapter to be compatible with ventilatory devices for the tracheostomy tubes. Those are the same devices where the end of the endotracheal tube, the 15-22 adapter. Ventilation is accomplished by attaching a BVM to a 15 millimeter adapter at the tracheostomy tube. Perform the suctioning through the tracheostomy tube as you would through a stoma for patients with thick secretions, right? So when a tracheostomy tube becomes dislodged, stenosis of the stoma may also occur. We as AEMTs do not perform deep suctioning, right? It's not a skill for you at all for deep suctioning. That means going deep into the lungs. Dental appliances can cause airway obstructions as well. So loose dental appliances should be manually removed before providing any ventilation. So take out the false teeth. Then provide your BVM mask and provide your ventilations. Any kind of facial bleeding, make sure you have suction readily available to protect the airway. To control bleeding with direct pressure as suction is necessary. Facial injuries are also associated with high suspicion for cervical spine injury as well. So if you're doing any kind of airway maneuver, make sure it's a jaw thrust. And also have inline stabilization of the cervical spine. As far as removing a foreign body airway, remember this is a true emergency. It usually occurs during a meal or a child who is eating, playing with small toys, or crawling around the house. So to recognize it, you want to make sure you look for the airway obstruction. If the patient can cough forcefully, although you may hear wheezing between the coughs, have them cough forcefully to get that out of the system. All right. Remember that they go unresponsive, we start CPR. The poor air exchange, the patient has a weak, insufficient cough or may have increased difficulty breathing, stridor, or stenosis. So signs of severe obstruction in the sudden inability to speak or cough immediately after eating. So if the patient was unresponsive, like I said before, start CPR. The only difference is when you're going to do back valve mask ventilation, look inside the airway and see if you can see something. If you can see it, take it out. If you can't, please do not stick your finger into a blind finger sweep. These right here are the King LT airways. They have the LTDSs and different versions of these as well. So this is the King LT airway, which is latex-free, single-use, single-lumen airway blindly inserted into the esophagus. This helps maintain. So this end here goes in the esophagus. This goes in the oropharynx, sealing off both ends, allowing for air to be delivered through the tube out these small little eyelets down here, allowing for oxygenation. They also have other ones called the King LTD and LTSD, and some of the differences would be the fact that they have a place for the OG tube. We place down the back side and go down the esophagus. That'd be more of a paramedic level. That's a paramedic level skill. They're available in different sizes as well, and they're all based on the size of your patient. So indications for this and contraindications: alternative to a back valve mask ventilation when a rescue device is required or a failed intubation attempt. Remember, you have to have end-tidal CO2 on these patients. This does not protect the airway from effects of vomiting and aspiration, though. That's a contraindication. So it should not be used in patients with an intact gag reflex, or patients with a known esophageal disease, or patients who have ingested caustic substances. So for those of you in New Hampshire, EMTs, you should already have very good familiarization with this, as it is a New Hampshire EMT skill. For Maine, obviously not. So again, we'll cover this more in detail during airway management during our practical sessions. We already talked about some of the complications: laryngeal spasm, vomiting, possible hypoventilation, trauma as a result of improper insertion. You can cause a lot of laryngeal trauma. Ventilation may be difficult if the pharyngeal balloon pushes the epiglottis over the glottic opening. So again, there are a lot of different studies on this, and they're really saying that the King airways are actually do more harm than good as well. So a lot of services and states are switching over to the eye gels instead. This is called an LMA, or a laryngeal mask, as it slides down into the trachea, as you can see here, and then it inflates, applying a distal tip here as a blockage for the esophagus as well. That's just another method. I have some of those as well we can look at during our practical day as well with that. Many advantages to these is with this: provides better oxygenation. Ventilation does not require the continual maintenance of a mask seal. They insert a lot easier. Usually in the ORs, if they're not intubating patients, they'll use LMAs. I've seen more LMAs used in the OR than I have in the field. It also provides protection from upper airway secretions as well. All right, so let me show you the picture of this one here. This is an LMA mask. So the next one I'm going to show you guys, getting close to the end, is your iGel. These are the more up and coming devices. They have the ability to literally, you measure it based on patient's weight. It inserts directly down the oropharynx and slides right into place. And you take a band and put it over the top of it, and it holds it in place, and you're done. There's no filling up of anything at all. It's similar to an LMA without any kind of inflation. And they also have the ability to put OG tubes down for paramedics. So the iGel supraglottic airway is actually a pretty decent airway. I know Vermont switched over to that years ago, getting rid of the King airway. This is what they call a Cobra PLA. I have not seen these in the field in many, many, many years, but again, they're covered though. This part of the airway is a Cobra shaped device, as you can see down here. So it goes into the airway and it provides that seal to hold it in place. Recommended for use in patients who are not at risk of vomiting. So as you can see, we really aren't sure if they'll vomit or not. So these are really not the best airways we utilize. The last one in here is the combi tube. which was a New Hampshire BLS device, which they took away a long time ago, and switched over to the King Airways. This is a blindly inserted airway that could be inserted either into the trachea or into the esophagus. So what you would do is you'd fill the balloons and you would try number one. If it doesn't work, then you try number two. The drawback with these here is there's latex in those. So you can either be in the esophagus, it contains 2 different lumens, and accommodates any ventilation device. Again, I have one of these as well. You guys can take a look at, but I have not seen these used in any services anywhere that I've ever worked for in years because I got rid of them, mainly because they were latex. But they found that they weren't working as the greatest compared to the King Airway. All right. So it should be used for patients only 5 feet to 7 feet tall. So again, it wasn't used for kids or pediatrics under the age of 16 years. So there were a lot of contraindications behind it as well. So complications would be like an unrecognized displacement into the esophagus, laryngeal spasm, vomiting, possible hypoventilation, trauma to the pharynx, esophagus from improper insertion technique, and ventilation may be difficult if the pharyngeal balloon pushes the upper glottis over the glottic opening. All right, so let's go to the last couple of slides here. So assisting with placement of an advanced airway. So those advanced airways that we talked about, those are all within, well, the iGel, and the King Airway are within the EMT scope of practice in Maine, sorry, New Hampshire, and is within AEMT scope of practice for Maine and New Hampshire as well. But a paramedic performs a skill, but the AEMT partner plays a central role. Helps get things set up, performs BLS airway ventilation, and also helps monitor the patient with this. So endotracheal intubation, insertion of a tube into the trachea to maintain and protect. This is what they call the golden standard of airway management. So pre-oxygenation, maintain a high flow nasal cannula on the patient. Intubation, which leaves the nasal cannula in place. And then the apneic oxygenation, which allows for continuous oxygen delivery down the airways itself. So we kind of pre-oxygenate the patient in preparation for intubation. We have different methods of using direct laryngoscopy, which is a visualization of the cords through a laryngoscope, or video laryngoscopes, visualization using a video camera and monitor. The success rate is way higher, obviously, utilizing video versus direct. Most services are actually going with the videos now. And a lot of them actually have recording devices as well that you can attach to your other points. Other insertion intubation equipment sets include PPE, obviously a suction unit with rigid tonsil tip Yankauer, or a French tip catheter. Laryngoscope handle and blades. They have Max and Miller blades, whether they're curved or straight. McGill forceps, those are utilized to pull foreign body airway obstructions out. ET tube size, which is size for a patient. Then they have what they call a stylet, or a tube introducer, which is what they call a gum elastic bougie. So there's different methods that are there. A water-soluble lubricant. This goes on the end of the tube to be able to allow it to slide through the tracheal, the glottic opening. A 10 ml syringe utilized to fill the cuff. Confirmation devices like end-tidal CO2 or colorimetric devices. Commercial ET tube securing devices and alternate airway management devices such as the supraglottic airway or a Craig kit. So for some reason that the intubation can't be done, they can switch back over to a blind insertion airway so the patient continues to be ventilated. All right, and then at the end, we have the 6 typical steps using the B-Magic mnemonic. Perform bag valve mask pre-oxygenation. Evaluate for airway difficulties utilizing the Mallampati score of 1 to 4. We're going to manipulate the patient and attempt the first pass intubation. We're going to use a supraglottic or intermediate airway if unable to intubate the patient. And we're going to confirm successful intubation and correct any issues that may be present. All right, so that is all I have for you guys tonight. Let me stop the recording here.